as a pathologist, many people ask me, Dr. Ding, what do you actually do? What do you do for your work? And I often explain that it actually very similar to what a fortune teller is doing. So you probably go to a fortune teller because you have a big decision you need to make for your life and you don't know what to do. So they look at the crystal ball and they don't tell you what to do, but they give you some idea how to process and make you feel better about your decision. And that's actually quite similar to what I do. I look at a microscope of tissue from patient that usually comes with a set of specific clinical questions that we want to address. And I write a report to address that, to help you and your doctor make important decisions for your treatment. But there are 3 important differences between a fortune teller and pathologist. Number 1, I do need to go to medical school and residency for that pathology job. And number 2, a lot of fortune tellers are pretty nice and they talk to you, they understand your feeling, but pathologists are often introvert and they lock themselves in the basement office. They don't talk to you. They write a report that is cold and not understandable, which is a little upsetting. And so I think that the purpose of my talk today is to help you in this short amount of time using prostate biopsy as an example to walk you through how to process this difficult to understand pathology report. Okay. So the purposes of pathology report is that we want to address specific clinical questions to determine the next step. A lot of time, back in the days, those reports are targeted for our oncologists and urologists or radiation oncologists to help you make decision. I think nowadays there's more awareness that patients should be in the driver's seat to make this important decision for their life. But unfortunately, a lot of language in pathology report are still quite not understandable and not very patient-centered. But another couple factors that make pathology report difficult to understand is that a pathology report also serves as a legal document. So I'll give you an example. Let's say you underwent a surgery at UCSF, and the surgeon say, well, we successfully take out your prostate, you're cured, you can go home very, no worry about it. However, how do you know that's true, right? So this piece of tissue come out from patient body, go to pathologist, which as a third party, not surgeon, not insurance company, not patient. We look at this piece of tissue as a non-biased third party, and we say, well, this doesn't look like prostate, this looks like a piece of fat. Ooh, there's some scandal in here, right? So we write this in the report, and this is a legal document because patient might not be very happy about that, right? The doctor is not the same as the operation report. So that's very important to document. And also it serves as a billing document. So what kind of procedure the surgeon was doing, what kind of test the pathologist do to diagnose the cancer, those need to be documented. So there's a lot of jargons and language that's really difficult to understand. However, there's good news. So now we are aware that patients are often getting this report very early in the process. So we want to make sure at least we are using a unified language. So at least when you Google what was diagnosis on your report, you get a similar, you can get a standardized result. And this has been done much better in the urine cytology diagnosis. They standardize their diagnosis into 6 categories and based on the different risk stratification. And we have done that a little bit in prostate cancer, so that's good news. So it's not terribly not understandable. Another good news is that because pathology report our medical document and legal document is very structured. So if you follow the structure, you pretty much can get a sense what's going on. So my personal recommendation is that you want to read your report, you want to discuss with your care providers because they know what exact question they were asking when they submit this request for pathology review. We also highly recommend to consider second opinion for your pathology report for GU specialized pathology expertise, especially when the report is in an intermediate risk and difficult for making decision. And I personally don't recommend discuss this with your AI agent. I know AI is really amazing, has been doing a lot of amazing work in biomedical research. However, there's so many personal information in your pathology report, so many. So I will be really concerned to give your pathology report in an AI agent that we don't know how they're going to use your data. I highly recommend not doing that. So unless you know it's really secure. Okay, maybe this might change next year, but currently all the AI model freely available online is a little question mark about the security of your information. So I just want to say that. Okay, so now I want to give you another example of why a biopsy report might be very different from a surgery report. So, because they are addressing very different questions. So as Dr. Kuberber mentioned that localized prostate biopsy, the goal is to find clinically significant cancer. And if there's cancer, what kind of cancer is that, right? But for a surgery, the surgeon already know the patient has cancer. So the question is not about whether there's cancer or not. It's about the extent of the cancer. Is the margin clean? Is there any unusual features present? So the report will be quite different. So I only have time for one example today, so that will be biopsy. Okay, so this is a typical pathology report structure look like. You will have patient name, specimen identifier to specify what kind of procedure, what date of the procedure, which are really important information. We will have the diagnosis of the tissue. Is it cancer, not cancer, what kind of cancer? We will have comment, which has a lot of details that our urologists are looking into. And there are also gross descriptions describing what kind of specimen received, and also addendum, and can be added multiple times after the case is finalized. So today I'm going to focusing on the top three structure of the pathology report. So this is an actual UCSF prostate biopsy pathology report. This, if you were here last year, you probably noticed this actually looks a little different because we actually update to a new system. And also we're adding more information about the canary pathology risk group that Dr. Kuberber mentioned. It's outside of the standardized Gleason score, but we put that as a table as a top of our comment. And I have to admit that even a person after medical school training and residency might still find this very daunting because there's like 5 pages of numbers and words of jargons. But let's take step-by-step approach. So first, I highly recommend, and many people miss that, but it's actually really important, is to look if this is actually your report. I know this sounds crazy, but a lot of medical error comes from specimen mixing up. You might find patients with a very similar name of yours, but luckily there's usually multiple identifiers, so, checking the date of birth, checking if the surgeon is your surgeon that ordered the review, and checking if the procedure date is correct. Are you making your decision based on the most updated biopsy report? So those are really important. And another thing to check is if this report is finalized. I know it sounds really ridiculous, but sometimes, because the pathology report, the way it processes, I look at the microscope, I come up with my diagnosis, I type in the computer, but I might think, well, I need more study to refine this report. So I might not finalize that report immediately. So I will say this is a preliminary report. I don't give this to our surgeon yet. But for some error, it might come to your end. I hope not happen, but that will be preliminary result that's not finalized yet. So it's important to check, and all the pathology report will specify that is if this is a final result. And then make sure the date collection is correct, and make sure this everything line up, which is very important. And sometimes pathologists can make mistake. And after the mistake was found and corrected, the case will be amended, and it's a legal requirement that we put that the report is amended. So what you will get in the system is an updated report, said amended report, and it will have the timestamp of when it is amended, who this pathologist talked to, which is also another requirement to make any amendment. And the outdated, the wrong report will be still in the system, but not available unless there's something coming up. So these are all details that might be relevant for decision making. Oh, yeah, I do want to say we do put our name on our report. So if you're thinking why your pathology report is so delayed, you can check. Why am I waiting for long? It's the pathologist's fault. Okay, and then just want to say that if it's a pathology report is amended, it will be very obvious at the beginning, and will tell you there's amendment, and that will tell you when was the case amended and why the case was amended. Is it a typo? Is it an error? And those kind of things need to be documented. So the step 2 is what we all here care about, is what to look in for diagnosis. So in our diagnosis line, we need to specify what tissue we received, what was the procedure, what's the location of the tissue, and what was the diagnosis. So that's how it was structured. So when you got a benign report, there's some language differences. Some pathologists will say benign prostate tissue, benign fibromuscular tissue to specify what kind of benign tissue they see. Some pathologists just say benign, which is also fine. But it's nice to know what was the tissue actually got biopsied. Sometimes you get this a little confusing diagnosis called atypical. Actually, most prostate localized biopsy, when you see atypical, it's actually most of the time low-risk lesion, if it's really a lesion. So there's 2 common language you might see in the prostate biopsy report. One is called ASAP, or atypical small acinar proliferation. And the other language you often see will be small focus of atypical glands, suspicious but not diagnostic for carcinoma. And these 2 actually means very similar things. That means they are a little suspicious about look like cancer, but they are not quite yet the diagnostic criteria of cancer. If they were proved to be cancer, they are not a high-risk clinical significant cancer for prostate. This language could be different if you are looking at breast pathology report or lymphoma pathology report. So don't do this to other type of cancer. But for prostate, this is pretty specific. This is a low risk if proved to be lesion diagnosis. And then if there is a cancer, the pathologist will state this is cancer, and it's prostatic adenocarcinoma or other type. And prostatic adenocarcinoma is the most common cancer type seen in prostate. There are other possibilities that's more rare. For example, ductal carcinoma, small cell carcinoma, basal cell carcinoma. They are treated differently, managed differently, so it's not in the discussion today. And also sometimes, rarely, you might see non-prostate cancer in the prostate. So for example, lymphoma, melanoma, bladder cancer. So it's important to know what kind of cancer is there. So then Gleason score. Gleason score still remains the standard of reporting the risk of prostate cancer, and it's based on the primary and the secondary pattern of the cancer that the pathologist is looking at. Caveat here is that we are looking at this on biopsy, which means we don't necessarily get the good representation of patient's tumor. So a Gleason score here is based on what a pathologist sees, but it's an estimation of how likely the patient's tumor actually is. So the lower the number usually means the more indolent of the tumor. So there are a lot of numbers here. On the left side, we have Gleason score, which you're probably familiar with. 3 is the first number is the primary pattern, second number is the secondary pattern, and they come up with a summary. And important to know that although the math tells us 3 plus 4 should be equal to 4 plus 3, but that's not true for pathology in prostate cancer. 4 plus 3 is actually a higher grade group compared to 3 plus 4, and is in a different risk category. And there's also other cancer-related lesions that we are now paying more attention to. One is called intraductal carcinoma. That is considered, for some pathology practice, they are not integrated into the tumor grading, but itself, the presence of intraductal carcinoma itself could be a high-risk predictor. And there's also other terminology, for example, atypical intraductal proliferation. As I mentioned, that atypical means a very specific thing in prostate cancer, and atypical here means that it's suspicious for this high-risk intraductal carcinoma, but it's not diagnostic for that yet. So we give this atypical at the first line, first word of the diagnosis. And the last one is high-grade prostatic atrial epithelial neoplasia, high-grade PIN. It has the name high-grade, but it's actually much lower risk than any prostate adenocarcinoma. So this actually considered as a precursor lesion of cancer, but it takes so long to become an actual cancer. People sometimes put them into benign category. Okay, so step 3, after you look at the diagnosis line, you want to see the caveat of your lesion, you look at the comment, and in UCSF, we now put a standardized table on the top of your biopsy, which include a lot of detail about the Gleason score and the coronary pathology pattern that Dr. Cooper just mentioned. And not only UCSF, actually many institutions provide some sort of a summary at the top of the comment because there's multiple cores of prostate biopsy, and it could be very confusing to read all of that. So they try to summarize the critical finding and critical things that are not found on the top of the comment. And the pro tip for everyone here is that I will highly recommend to pay attention to the types of Gleason pattern 4. So the standard of pathology report all over the United States is you have to report at least is there any cribriform present. And this is a specific form of prostate cancer that could be aggressive. And in UCSF, we also report other type of Gleason pattern 4, but we definitely include this one. We actually put it in the top line to say if we see this pattern in the tumor, yes or no, to help our clinician to make more fine risk stratification. And then after that summary table, there's usually some comment about what kind of test was done for this pathology tissue. So those are often for billing purposes, so you don't have to pay much attention. But for a lot of urologists here and also radiation oncologists, they actually go to the details of how many core has cancer, how long are they, do they involve the nerve? So that kind of summary in their brain to help them decide what kind of surgery or like different treatment options they will recommend for you, which will be discussed later today in the meeting. So summary, we give you the step-by-step protocol to look at your pathology report. Number 1, check if this is actually the right report. Number 2, checking the diagnosis. Number 3, checking the comment. And pro tip, look at different type of pattern 4, the percentage in the comment. And actually, I do want to mention one thing that I think I put it in my slide, but I forgot to mention, is to be careful for any tumor less than 0.5 millimeter, because the grading could be pretty problematic in small lesion. So this actually is a kind of controversial grading that you might want a second opinion for pathology. And step 4, which is very important, and I'm sure all of you are doing, is discuss your report with your care provider to form the decision making for a next step. And finally, if a pathology report is confusing, or is it on the fence of making one decision over another, I highly recommend to get a second opinion. I actually listed a couple recommended GU pathology consultation service. I'm a UCSF employee, so I'm obviously biased that I recommend UCSF GU service. But there's a couple in this country that is very have high turnaround time and highly respected GU service. Cleveland Clinic actually provide a similar histology subtypes common as compatible with UCSF, so it will be interesting if you are thinking, I'm not sure if this UCSF pathologist is making the correct comment about my cancer. They actually provide a similar comparable comment about the coronary histology subtype. But for standardized Gleason score, Johns Hopkins and Advanced Urology Pathology at New York, which is run by my mentor, Jonathan Epstein, often provide pretty decent second opinion consultation. So with that, I hope this helped you to understand a little more about pathology, and if any question, because I basically hide in my basement office, please email me. I will be happy to address that. Thank you.